Hi, good evening, everyone. I hope y'all are having a good Wednesday. Thank you for being here with me today. I'm Dakshini, and I serve as a medical officer at the National Cancer Society Malaysia. And today I will be talking on an important yet topic that doesn't get enough attention, and that is skin cancer. And so today I will be talking on how to identify the early signs and also when to seek treatment promptly so we can prevent avoidable mortalities. So, next. So, what is skin cancer? Skin cancer is uncontrolled growth of cells within the skin. So, when would a tumor develop? So, a tumor would develop when there is some sort of DNA mutation, which leads to uncontrolled cell division, and then you get a mass or a tumor. And typically, these mutations they occur in proto-oncogenes, which result in promotion of cell division, or mutation in your tumor suppressor genes, which result in loss of inhibition of cell division. So you can, in other words, think of proto-oncogenes as your accelerator or gas pedal, and your tumor suppressor genes would be your brakes. So too much acceleration or an inability to brake would lead to uncontrolled cell division. And as a result, your mutated tumor cells will start piling up and then they become a tumor mass. Next. So from here we can see that tumors can either be benign and or they can be malignant. So if they're benign, as you can see in the first picture, they are very well contained, they're neatly organized, they're not invading into the next cell. But in the next picture, they are malignant or tumor, they are cancerous, and so they break through their basement membrane and they invade nearby tissues. So they can invade into your blood or your lymph vessels, and they can travel from the primary site and then travel to a secondary site to form a different tumor. And this is called as metastasis. Next. So it's important to know what the risk factors are that make us most susceptible to getting skin cancer. So the most important one is UV rays or ultraviolet rays, either from the sun or even artificial UV rays from tanning beds. So prolonged exposure to your UV rays or even the sun increase your risk of skin cancer by causing DNA damage and then mutation in your skin cells. Fair skin or fair haired people, because of their insufficient skin pigmentation, they have less natural protection against UV radiation. So this makes them more susceptible to skin cancer. Next would be scars from severe burns. They also make you more susceptible. Why? Because when your skin regenerates, they don't naturally always regenerate normal skin structure, and this would lead to abnormal cell growth. Exposure to chemical pollutants such as arsenics or nitrites, coal, all these things also introduce carcinogens that can damage your skin cells. Ionizing radiation, either from medical treatments or environmental sources, can lead to DNA damage as well. Chronic skin irritations such as psoriasis, eczema, this can create an environment that's very conducive to cancer cell changes. Next. So today, I'll be talking on three major types of skin cancers, which is basal cell carcinoma, squamous cell carcinoma, and melanomas. So the most common ones, especially in Malaysia, is basal cell carcinoma and squamous cell carcinoma. Next. So diagnosis of skin cancer starts with naked eye skin examination of the characteristic of the lesion, as well as a detailed history of the current skin complaint. Important to ask about the time of onset, the duration, location, evolution of how the changes of the skin lesion happened, and of course, any associated symptoms as well. This is then followed by dermoscopy. Dermoscopy is a non-invasive technique used to evaluate skin lesions. And this allows us to visualize the subsurface skin structures in the epidermis and the dermoepidermal junction and upper epidermis. So the main purpose of a dermoscopy is to decide whether or not you want to monitor the lesion or whether you want to perform a skin biopsy. And a skin biopsy is needed to confirm a diagnosis of skin cancer, where it will show you the type of cells that are involved. Next. So Skin biopsies, there are three ways we can perform skin biopsies, and the main three ones are shaved biopsies, punch biopsies, and excisional biopsies. So in shaved biopsies, a superficial thin piece of skin is removed from the surface using a small sharp blade. And this is typically for lesions where you don't need to sample the full thickness of the dermis. On the other hand, punch biopsies involve removing a core-shaped piece of tissue using a sharp cutting tool, and this would allow sampling of the deep dermis as well. Finally, you have excisional biopsies, and this consists of removing an entire area of skin, including the entire lesion and a portion of normal skin around it, and this is preferred for pigmented lesions. Next. All right, so coming to the first cancer, skin cancer. So skin cancers is differentiated based on the type of cell that's involved in the tumor mass. So the most common of all the skin cancers is basal cell carcinoma, and it involves cells that are in your stratum basale. And these tend to be fairly slow growing tumors, but they can be very locally invasive, but they rarely metastasize the distant regions of your body. They are common to appear over your sun-exposed areas, such as your face, your ears, your neck, your shoulders, and back. And if not detected early, they can be quite locally destructive. So next, coming to the features of how a basal cell carcinoma lesion would look. So as you can see, they're very small. They're very well circumscribed. You can see it's a very nice round shape. They're waxy, kind of translucent, pearly borders. And they can have some small vessels that cover the surface. And in the middle picture, you can see there is central ulceration. Sometimes there can be crusting, and they're very common to appear on your face. So next. So how we would treat basal cell carcinoma, there are many ways that we can treat. So wherever possible, the first choice of treatment is always surgery. And it's typically an outpatient procedure. So surgical excision would be removing a chunk of tissue using a scalpel, and then you would approximate the defect. So after you've removed that chunk of tissue, you would approximate the two sides either by using tissue flaps or grafts or even just side-by-side closure. Or there is a specialized surgical technique called as Mohs micrographic surgery or simple Mohs surgery. And this is where the tumor is surgically excised and then immediately it's examined under a microscope. And this is to see if to verify if there's sufficient margins before you surgically repair the site. So if the margin is insufficient, you would go back, remove more tissue until the margin is sufficient. So how this is better than a standard surgical excision is it allows you to control your tumor margins while minimizing the amount of normal tissue that you're going to resect. So next you have curettage and electrodesiccation. It's an alternative treatment for patients who maybe don't want to have a surgical procedure or a surgical excision done. So first you would use a curettage, which is a curette or a round knife to scrape off the cancer down to the dermis. And then you would use electrodesiccation to burn the dermis layer with an electric current. And you go back on it with a curette to remove more of the denatured dermis down to living tissue. So until you see clear margins of normal tissue, that's when you stop. So next is cryotherapy. So cryotherapy is when we use liquid nitrogen to freeze and destroy the tumor. But this is rarely a treatment for skin cancer, but it is an option. So next, some superficial cancers, you can use topical therapy. So topical therapy with fluorouracil, which is a chemotherapy agent. So you would apply this for a few weeks. And sometimes there can be inflammation, but this is usually just for superficial lesions. And finally, basal CA can also be treated with photodynamic therapy. Photodynamic therapy uses photosensitizing porphyrins, which is topically applied over the tumor. And then the area that is involved is exposed to visible light. And then the light will penetrate the skin and selectively absorbed by the photosensitizer, leading to tumor destruction. So But this particular technique, photodynamic therapy, has a very high recurrence rate as compared to the other options, so it's not usually performed. Next. So, coming to our next carcinoma. So, the second most common type of skin cancer is squamous cell carcinoma, which involves your squamous keratinocytes, which is a different cell in your skin. So, one of the three main types of it's still one of the three main cells in your epidermis, which is the topmost layer in your skin. And it is frequently, again, similar to basal cell carcinoma, commonly occurs on areas that are exposed to the sun most. And it is less common than basal cell carcinoma, but it is more aggressive and has very high potential to metastasize and may lead to death if you don't treat it early. So squamous cell carcinoma specifically can be further divided into three stages. So actinic keratosis, Bowen's disease, and invasive squamous cell carcinoma. So first, actinic keratosis, which is a precancerous lesion, and it's where keratinocytes have been damaged by radiation and they begin to overproduce keratin. And this would form dry, rough, almost sandpaper-like patches around the skin that is exposed. And again, they commonly appear over your skin, your lips, your face, your scalp, arms, or even the back of your hands. Then it would progress to Bowen's disease. So Bowen's disease is an early stage of squamous cell CA. So just now, actinic keratosis is precancerous. Bowen's disease, it's already cancer, but it's stage 0. And so that's why it's called squamous carcinoma in situ. And so this usually appears as small, again, well circumscribed red elevation with scaly plaques. And at this point, the tumor will be found in your epidermis, but it has not broken through the basement membrane to spread to your dermis. So if it extends into your dermis, then that means it has broken through your basement membrane, extended into your dermis, and even reached your hypodermis. This is already considered an invasive squamous cell carcinoma. And as it enlarges, the central part will become necrotic, and then it will turn into an ulcer. So so this is more examples of what squamous cell carcinomas look like. So they, as you can see, they're red, scaly patches. They have open sores, and they look thickened, like the skin is thickened, almost wart-like, and there's central depression around the thickened area. So treatment depends on the stage of the cancer. So when it's still at actinic keratosis, which is precancerous, it can be treated with cryotherapy, topical therapy with fluorouracil or imiquimod, or even photodynamic therapy. This is to prevent it from progressing to Bowen's disease. But once it has reached Bowen's disease or even further invasive squamous cell carcinoma, it has to be sent a surgical excision, or Mohs surgery is the first line. Next. So finally, the most aggressive form of skin cancer is melanoma, and this involves melanocytes. So this is another type of cell in your skin, and these are cells that produce your pigment. So melanocytic nevus, or otherwise known as a mole, results from a type of melanocyte that overproduces melanin. So these moles can be considered precancerous because they carry an increased risk of becoming a melanoma. And so melanoma, they can spread horizontally within your epidermis and also vertically into the dermis. And it's mostly associated, metastasis of melanoma will mostly associated with the depth of the invasion. And it's also known as the deadliest form of skin cancer because it metastasizes very, very quickly. So the worrisome signs of melanoma can be very easily remembered using a mnemonic A, B, C, D. So A, because they are asymmetrically shaped. B, their borders are irregular and even notched. Their colors varies within the same lesion. They would be larger than 6 millimeters, or roughly the size of a pencil eraser. and also it rapidly evolves, and there will also be skin elevation. So these are features that you can just see, and once you notice them, then you would need to get it further examined with a dermoscope. Next. So first, we would do a dermoscope, and from there, for definitive diagnosis, we would do a complete full thickness excisional biopsy for suspicious lesions, and we would take 1 to 2 millimeter margin of normal skin as well, and part of the subcutaneous tissue if you suspect melanoma. And this would tell you the tumor thickness as well as the characteristic of the tumor. So next, if melanoma is confirmed, we would go back in to do a wider surgical excision. And this is to reduce the risk of recurrence. So from this table, you can see based on how much the tumor has spread, that is how much normal tissue you would need to excise along with the tumor. So in situ, meaning it hasn't invaded into the adjacent cells, then you would remove 0.5 centimeter margin of normal tissue. If it's less than 1 millimeter thick, then you would remove 1 centimeter margin of normal tissue. And if it's more than 1 millimeter thick, at least 2 centimeters of margin of normal tissue needs to be removed. And for those with higher risk of recurrence, such as with tumors that are more than 4 millimeters thick, or there's presence of ulceration, you would also give adjuvant radiotherapy. Next. All right, so that concludes all the skin cancers that I'm covering today. So, but important is you need to do your skin self-examination. So next is coming to how we would identify any lesions that we would have. So regular skin examinations are so important for early detection of skin cancer. So patients that, or if you know that you have increased risk, such as you have history of skin cancer, you have family history of skin cancer, you're light skinned, you have had significant exposure under the sun, you have a weakened immune system, you will need to do your skin examinations more regularly. And if you don't know if you have high risk, then you should consult your doctor or your healthcare professional to know how regularly you need to do this. So you need to familiarize yourself with all the moles, blemishes, and freckles on your skin. And you need to notice if there are any new moles or any changes in your existing moles, and any of this occur, you need to get it checked as soon as possible. You should best time to conduct your self-examination would be after a shower or bath under good, like a well-lit room, using a full-length mirror in front of you and a handheld mirror so that you can see the hard-to-see areas. And always follow a systemic process so that you don't miss any areas when you're doing your self-examination. And if there are any parts that are difficult to see or examine yourself, get someone to help you. So how you would perform your self-examination: first, stand in front of the mirror. First, you would start with checking your face, your ears, your neck, your chest, and belly. And for women, you would need to lift your breast and also check underneath the skin underneath. Then you would check under your arm areas, both sides of your arms, the tops of your palms and of your hands, and between your fingers and also under your fingernails. Next, you would sit down, look at the front of your thighs, the shin, and the top of your feet, in between your toes, as well as under your toenails. Now you would use your hand mirror to look at the bottoms of your feet and calves, and also the backs of your legs and thighs. And you do this one leg at a time. And then use your hand mirror or look in front of a long mirror with your handheld mirror to check your buttocks, your genital areas, your lower and upper back, and the back of your neck and ears. And lastly, use your comb or a hair dryer to part your hair so that you can check your scalp as well. So it's a super easy way to do your self-screening, and you'd be able to save yourself a lot of treatment, unnecessary mortality, if you just do these simple steps. So that concludes my presentation for today. The floor is open for questions if you have any. It can also start on covered body parts, yes. It's just more common to appear on sun exposed areas of your skin. Sunburns are a risk factor. It's not a definitive thing that will turn into skin cancer, but it is a risk factor. Just severe sunburns, not like small sunburns that resolve and heal. Usually, no, but it is a risk factor. If you have a lot and very severe sunburns, then yes, it is a very high risk factor. An injury wound, squamous cell carcinoma can occur from any sort of mutation. So even an injury, yes, it can. Any exposed area, exposed to chemicals, all these things are considered as injury as well. So if you think that it looked like one of the pictures, I suggest you get it checked. Okay, so I guess those are all the questions. So to summarize, so we've talked about three main skin cancers today, which is basal cell carcinoma, squamous cell carcinoma, and also melanoma. So the commoner ones in Malaysia being basal cell carcinoma and squamous cell carcinoma, and treatment will always be firstly to do surgical excision, or if it is in its precancerous stage, we can do cryotherapy or even photodynamic treatment. And if we detect that it is highly likely to be cancerous, we would do a skin biopsy to confirm, and then finally proceed with treatment based on the severity of your cancer. And importantly, you need to do your skin self examinations regularly, especially if you're high risk, and seek healthcare professional help if you do notice any lesions. So that would conclude our topic for today. And thank you all for joining me. And I will see you guys in the next one. Good night.